So welcome to our exosome breakout session. My name is Dr. Duncan Ross. I am the founder of Chimera Labs.
And my name is Doug Spiel. I'm the Chief Medical Officer. He's the Chief Science Officer. And we have a very unusual relationship, the two of us. For most of my career, I've been entirely working on the bedside and had no knowledge of the bench. And he's done a lot of bench work. So we have the ability to go back and forth, which is kind of an unusual relationship for the two of us. 2 years ago, I was sitting where all of you were, and I heard Duncan speak, and it blew my mind. And I sat there, and it was during the Zika outbreak down in Florida, and I flew home, and I told my pregnant wife that I had to go back and see somebody in Miami. She goes, "You just got back." I said, "I need to leave again." So I left. I spent a day with Duncan, and I started using all of his products, and I was a blender. So I started using exosomes in conjunction with stem cells from bone marrow, from fat. And I used them pretty much side by side for about a year. But a year ago, I switched over. My entire practice now is exosomes with or without a scaffold, either PRP or PRFM. And we can go through reasons why I would use one or both of those. Before you today is a chapter that's being published in ASIP's Regenerative Medicine textbook next month. And it talks a lot about the science of exosomes. Privately on page 22, there's a number of my protocols that I use privately in my private practice in New Jersey, and we'll outline and we'll touch on many of those today and how we do those things. Duncan, maybe it's helpful to give them a brief understanding of how mesenchymal stem cells work and why we use exosomes.
So let's discuss what an exosome is. An exosome, and we're here to talk about tissue-related therapies. An exosome is the secretion, the 100 nanometer lipid vesicle secretion from a mesenchymal stem cell and from many other types of cells. But for the sake of today's discussion, we're going to talk about mesenchymal stem cells. And it has been found in the last couple of years that that is how cells communicate. When you think of proteins running through the entire circulatory system, proteins are very labile. They are broken down by proteases that are in the environment. Messenger RNAs are very labile. They're also broken down. So in my mind, I could never quite understand what paracrine effect meant, even though I've read it since the beginning of my career. Because I also used to express proteins, recombinant proteins, and I know that when I express a protein, I have to run to the bench to do my next assay, otherwise that protein's not functional. So the concept of how this was working was very difficult for me. When I was expanding all kinds of adult cells, mesenchymal stem cells, I found that some cells did not proliferate well. In one very important case, because it was the wife of a surgeon that I work with, I couldn't get the cells to grow. But I understood that there was a paracrine effect. I had tried everything else. So I took the supernatant from one set of cells and put it onto the old cells, and the old cells started growing. And that was kind of this eureka moment where I thought, wow, I don't need the cells. All I really need is the paracrine, and at this time I'm thinking proteins, right? So by doing a little bit of research, and this is back in 2014, I started finding that in Singapore and China, there was starting to be a lot of work on this conditioned medium that is called, the medium that the cells are growing in. And it was found that what's affecting these changes are these lipid vesicles, which are encapsulating the proteins and, more importantly, the messenger RNA of those proteins, so that they're not affected by the environment, so that they're not broken down by these proteases. And the beauty of this is actually that one messenger RNA can make thousands of proteins over a period of up to 1 month. So now look at how much more effective that message can be if it can be replicated by whatever cell the exosome ends up with thousands of times. So in effect, you could think of it like this. You could take one cell and have it express kidney tubular epithelial cell type of proteins, put that into another cell, and turn that cell more or less into a tubular epithelial cell without that cell's DNA having to upregulate any expression profiles. And in reality, that's how our cells communicate. That's how our cells communicate being infected by a virus, because really a virus replicates in the cytoplasm. It should kill us. It should beat any efforts to stop it. But by the first cell, sacrificing itself, but it does upregulate that antiviral machinery, it can tell all the cells around it that there's a virus in the neighborhood, and they start upregulating their antiviral machinery. So I just want to say one thing he said about Zika. You came during the Zika time. The beauty of the way the exosomes we're talking about are made is we have been using the same donor since I started this project. For the last 3 years, we've been using the same donor. So I know that this donor doesn't have Zika because I tested it. I know it doesn't have Epstein-Barr virus. I know what the protein milieu that it expresses is. I know the messenger RNA, and it's really nice to be able to do this kind of research on one set of cells, rather than having a new drug every time you have a product.
So he talked, and he's going to speak a lot more about the cell biology. And whenever you have questions, he's the guy to ask. He's the micro guy. I'm more of a macro guy. But let me take a step back with all of you for a minute. When I first came in, I came to these congresses, and I was trying to learn what's the best cell. Is it the Wharton's jelly, or is it the umbilical cord, or should I be doing autologously from your fat or your bone marrow? A couple of things are very important. Arnold Kaplan had a very sentinel paper, I believe it was 1991, where he talks about mesenchymal stem cells because they could turn over and they could turn into many different cell lineages, into skin, into bone, into nerves, in the petri dish. But we've found over time, over the last number of decades, that just because in the petri dish I can drive an MSC towards skin, towards nerve, towards bone, in the body it doesn't work that way. So if I take your SVF and I put it in your knee, or I take your bone marrow in your knee, or I go allogeneically and I take umbilical cord blood or Wharton's jelly and I put it in your knee, we used to believe that those cells would make new cartilage and they would engraft in your knee. Not so. The vast majority, 99+% of those cells will traffic out. They'll go to extramedullary hematopoietic organs. They'll go to your liver, your spleen, your lungs, your bone marrow, your lymph nodes, but they won't stay in your knee. But your knee gets better. Your knee gets better because of the secretomes and the microvesicles and exosomes that they secrete. And the PhDs have come up to these congresses and say, yeah, but you need cells. You do need cells. You need the resident stem cells that are resident to your knee. There's at least 5 different cell lineage cells, cartilage precursors, bone precursors, synovial precursors that live in your knee quiescently, silently, waiting to be turned on. And they're not turned on. So the big question, the second question I generally get is, well, if I've been using 3 million cells from Wharton's jelly, what's that equivalent to? A couple of things. If you start with bone marrow, 1 out of every 10,000 cells when you're a newborn in your bone marrow is an MSC. By the time you're 70 or 80, it's 1 in a million, 1%. Your fat cells, you lose about 10% per decade. So at 70, you have 30% of what you started with. But my cells are 53 years old. And Duncan will tell you that when I was born, my cells made over 300 different proteins. Right now, 100. And if I have Lou Gehrig's disease, 40 or 50, right? So I'm making less. Now, the allogeneic cells may be a better choice. And we use allogeneic cells from placenta. We pick those MSCs out to create our exosomes. But if you actually give them the cells, look at what happens. The companies will tell you there's 10 million or 20 million cells. Not stem cells. Maybe 1 to 3% of those are stem cells. And 50% are live. Well, after you go through the freeze-thaw cycle and the DMSO sees your cells, not very at room temperature, they're not going to do very well. And maybe some are still alive and wiggling around. But the people in the ICU, in bed 9, on life support are alive, but they're not very vibrant. Still, if the low-hanging fruit is a mild OA of your knee, you're probably going to get better because some of their secretions will still be liberated. We're giving you, with exosomes, an alternative therapy that's a lot more concentrated. What do I mean? When I first asked Duncan these questions, we had to figure out what is the equivalent dose or the equianalgesic dose that many of the anesthesiologists were coming up and asking us. What is the equivalent of MSC numbers to exosomal strength, to the amount of milligrams of exosomes? So we looked at some predicate data. In the research journals, and they're included in the chapter, I found that 1 million cells from one research paper tracked for 24 hours, cured, and then the solutions basically washed off, created about 100 micrograms or 0.1 milligrams of exosomes. In another study, I saw 60 million MSCs produce 1 to 2 milligrams of exosomes. In our 5 ml vial, we have 15 milligrams. So by the best approximations, that would have taken 150 million cells over 24 hours, washed according to that protocol. Now, what's IP to us is how we get them and how we create that final concentrated product. And that's two of the barriers really to this industry, is the ability to scale and the ability to concentrate that he's figured out. From an application perspective, I'm going to let him talk a little bit about the generic exosomes that we have right now, which are taken from placental-derived C-section MSCs. And I want him to talk specifically about the pro-growth and immunomodulatory nature of those exosomes.
Right. So there are two things that we want to achieve in this room. That is lower inflammation and instantiate growth. None of us are growing. The idea that instantiating growth with an adult cells doesn't make sense because those cells aren't secreting growth factors anymore. However, we do see a lot of benefits with these stromal vascular fraction therapies, etc. But I would argue, bone marrow, that it's because of the anti-inflammatory milieu that you have there, not a growth cascade. We also wouldn't want to grow forever, right? We stop at 20 for a reason. I like to use this as an example. It's not growth, but lactase. We're supposed to be lactose intolerant when we're older. We are obviously lactose tolerant when we're younger. We have that DNA. Nothing happened to it. But it did get covered over such that the expression of the lactase enzyme stopped. Every growth factor protein works in that fashion by design. But if we want to instantiate growth, we're going to need to cause those proteins to be expressed again. That is the thought process behind using a placental cell instead of an older cell to make exosomes. A placental cell exosome is whatever the interior milieu of that placental cell is. And what is that milieu? It's young, it's not tumorigenic, it's anti-inflammatory, and it's growing. So it's secreting all of those proteins. And by replacing them into an adult, we're able to express those proteins for a short period of time. So I would argue that the way to keep us alive forever is by growing, stopping, and being able to control it. What's nice about the exosomes is the messenger RNA go away in somewhere under a month. Some of the messenger RNA going away in hours, but some persist for up to a month. So in that fashion, we're able to not only express the proteins of a younger child, but also express proteins that will change the DNA expression of other proteins in that cell. So you have something called a histone acetyltransferase and histone deacetyltransferases. The way to express a gene is by adding a methyl group onto the lysine of a histone. The DNA is wrapped around the histone. When you put that methyl group on there, it opens the DNA, and now transcription factors can get to the gene and express it. So by putting those into our cells, we open genes that haven't been opened for 40 years, 50 years, and they can be expressed for a period of time. They'll be closed again, but they can be expressed for a period of time. The one thing you might worry about, as we were when we started, was, is this going to cause a tumor to form? Is this going to cause uncontrolled growth? Well, part of what a young cell does is young kids don't get cancer, do they? They don't get cancer because they're expressing the right tumor suppressors. Over time, our tumor suppressors get covered over by, they become unmethylated. They're not expressed, so we get cancer. I mean, sometimes it's DNA mutations that cause it, but I'm going to argue that many times it's the lack of expression of tumor suppressor genes. And in fact, elephants have been shown to have many, many copies of tumor suppressor genes. We only have 2. So by putting, it has been shown in some studies recently that exosomes from these young cells are able to stop the growth of a myeloid tumor in vitro. So it'll be interesting to look at what further outcomes we have going forward.
So in order to really understand on a real macroscopic view what he just told you, there's been studies that have been going on, and they're still potentiated in areas like Stanford and Harvard, where they've taken old rodents and young rodents and sutured them together. They're called parabiosis. In parabiosis, you take a very old animal and a young animal, you skin them, and you suture them together. And within a couple of months, the animals are euthanized, and the older animal looks morphologically younger, and the younger animal looks morphologically older. So before I tell you why that is, I will tell you there's at least 2 companies on the West Coast that will sell you the plasma of younger people for you to be younger. First of all, you should realize that stem cells are not being treated back and forth between those 2 rodents. There's simply not enough of them in your peripheral circulation. what is being transferred back and forth due to the fact that stem cells are pericytes and live on blood vessels are the stem cell secretions. So you're getting a very weak secretome so that the older animal is getting the younger secretome and the younger animal is subsequently getting the older animal's secretomes. Well, the reason these things make changes is because we have resident stem cells and we have anabolism, which outdistances catabolism in our youth. But by the time we hit our third decade, we're headed for the skids. So we're simply not keeping up with the catabolic nature of our bodies. Part of which is we're shutting off certain genes. Also part of that is that these resident stem cells become senescent. They're sleepy, they're in bed, they're not doing anything. If you change the milieu around them, you can wake them up and they can transdifferentiate into their normal cell lineages. By the same token, not a lot has been said about the younger animal who now appears older, and we've advanced his aging. The reason that is there are senescent associated secretomes from these senescent cells that are anti-aging, that are pro-aging, that will then age the younger cells. So too many senescent cells, not good, because A, they don't die off, and B, their secretions are catabolic. They're pro-inflammatory, and they yield to increased autophagy and basically cell death, apoptosis. So,
not to interrupt you, I'll give you right back. But it's at this point I'd like to remind you, we're discussing placental mesenchymal stem cell exosomes. Many, many cells secrete exosomes. So if you tell your patients you use exosomes, the first thing they're going to come across is tumor exosomes because they're being used
tumor markers you can pick up. So you can pick up you can assay the exosomes and the secretions of your body, just like we assay inflammatory markers. So I believe in our very near future, we're going to be able to have an anti-aging longevity serum. We can give you younger patients exosomes, really from placental-derived MSCs. So how would that play out, and how do I know that that would work? So I'll give you some of my own patient stories, and you can figure it out from there. I had a gentleman come in May, and I spoke to Duncan about him. Duncan had had some benefits through one of his doctors in Florida. The patient had ulcerative colitis, and they had had a number of distal enemas utilizing exosomes, and the infertile woman had become fertile. And he said to me, he goes, I think that the oocytes are no different than the other stem cells throughout your body and these progenitor cells, and they're, for some people, more quiescent, more early, and maybe we can kickstart them. I said, well, I have another guy that just walked in with azoospermia. So for 8 months, he's been going to a fertility clinic, 0 sperm count, 0. 6/29, I gave him an infusion of exosomes. 7 July of this year, a month later, 0. In early August, he comes back with a paper. He's happy. There's 700 sperm. Now you need 30 million sperm to be able to conceive. I said, you're not there yet. This week, he came in with a sheet from 9/6, which is roughly 3 weeks ago, or 9 or 10 weeks after the infusion. 90.4 million sperm. 90 million. So clearly, we've woken up that milieu. I do a lot of work with a lot of things where I think the bar is quite high. So I do a lot of neurodegenerative diseases. I do spinal cord injuries. I don't think it'll play out well here, but maybe I'm going to go around and just show it anyway so that some of the people here can understand some of the stuff that I have. I have a very interesting patient. This young man was a cheerleader at LSU, and he is very beloved by the LSU staff. And he actually got covered by one of the local TV media down, Channel 9 News in Baton Rouge. So he's a real guy. His name is Chico, and he understands that I talk about him now because he's one of the more recent guys that I've treated. And I treat a lot of spinal cords and brain injuries, but this one is quite striking. If you look very closely here, the gray is the spinal cord. This is as near to a complete transection as any of you will ever see. So this happened in a boating accident 7 years ago. For 7 years, Chico hasn't moved his arms or his legs. His mom is a lovely woman that takes care of him. His dream really is to pet his dog. He's in his mid-30s now. He was the cheerleading coach of LSU. Very well beloved in Baton Rouge. He hears about me through another patient, decides he wants to come up and get injected. And there are some protocols to doing some of these injections that include CAT scans or MRIs or even some angiograms. So I took a look, and in August of this year, I put a needle in, and there's a radiograph of the needle, which goes into a cistern, which is a fluid-filled space around his spinal cord. Well, with many of these spinal cord injuries, you see autonomic dysregulation. So a lot of them, high cervical cord injuries, you see a significant hypotensive episode that persists their whole lives. They either have postural hypotension or they may have hypotension all day long, and many of these patients take midodrine and other sympathomimetics to elevate their blood pressure. He was in the process for the last 7 years of taking 3 midodrine a day. After 5 days, he stopped his midodrine. At 2 weeks, he called me up. He said, Doug, he said, I can feel things in my arms and my legs, and I have sensation in my groin and my rectum. What can I expect? I said, son, I think anything more than that is a long shot with you. I'm not God, and I don't get to choose. He sent me this last week, and I hope it's as striking to you as it was to me. Here, you will see him doing squats on a sled, pushing with his quadriceps and thighs, muscles that haven't worked in 7 years. So now the question is, did I rebuild his spinal cord in this short period of time? Well, I can tell you conclusively that the MRI will look exactly as it looks right now. The first 6 weeks or so, I see changes in the inflammatory milieu. I believe that he had some fine filaments that were able to conduct some motor signals, and by changing the degree of neurotransmission, because I've seen this now in dozens of patients, you're able to increase their ability to use motor and sensory to some degree. There are forms of MRI known as diffusion tensor imaging where you can look for white matter tracks over time. I like to tell patients that their neuropathic pain, some of their visceral symptoms will get better. Some of them are developing bowel and bladder function. The first 6 to 12 weeks, I think, is predominantly anti-inflammatory and increasing neurotransmission far more than it is building cells. Beyond 6, 12 weeks, I would agree with you that we're seeing changes now over time. I have Parkinson's patients who come in on canes that within 3, 4 months can run and catch footballs. I have Alzheimer's patients that have shown cognitive changes in as little as 2 weeks. I have seen motor changes with spinal cord injuries in 2 days. We're seeing really remarkable findings, and we see them with autoimmune disease in my practice. I see them with neurodegenerative diseases. There's a number of us around the country now doing neuropathy, peripheral vascular disease. I do disc injections, and certainly shoulders, hips, and knees are the bread and butter for everyone that will be listening to this, and for those of you listening here today. The objective here is to teach you about the mode of treatment. Duncan will educate you on why it works on a cellular level, and I'm going to give you some protocols of how you can start using this today. So you want to speak a little bit about the process in layman's terms? So that gentleman, I injected intrathecally and intravenously. So as part of the protocols, you can refer, I have everything included on that page. If you have specific questions afterwards, we're happy to discuss that. Generally, I use 24 milligrams intrathecally and 45 milligrams intravenously. And I do that agnostically to every spinal cord, brain injury, neurodegenerative. I don't differentiate. I know that that is a level that works, and I'm not cross-training and testing people with different dosages at this time. Stroke, it works, sure. So all of these, what's very important, and I'm going to have him talk about the microglia response. I'll give you the macro big side of it. For patients who have strokes or spinal cord injuries, unlike the ankle inflammation that lasts for a couple of weeks and the activated microglia or macrophages in that change over to an anti-inflammatory macrophage in the peripheral body, in your central nervous system, Once inflammation, always inflammation. So there have been studies where they've taken ligands that bind activated white cells, microglia, M1 type, and they've shown two things. They've shown activated microglia for decades after injuries, spinal cord and brain injuries, and they found these activated microglia remote from the site of injury. So right side of the brain down to the thoracic spine. Cervical spine, thoracic, all the way up to the brain. So problems with these neurotransmissions, you see funny things with the spinal cords and brain injuries. Some people, you have autoimmunity, and you also have diminished immunity. So sometimes you can get the same bag in the same patient. There is absolutely a tie-in between the peripheral immune system and the central nervous system, and maybe you can speak intelligently as to that.
Well, you would previously we thought there's no immune system in the central nervous system. Well, that's incorrect. If you have 10,000 white cells per microliter in your circulation, you have 4 T cells per microliter in the central nervous system. So there is a crossover, and it's actually here around the thymus into the central nervous system from the lymph nodes, the periphery.
Is there any thought of the use of exosomes like
So let me take you through my clinical reasoning. So basically, after you have an MI, you have an anoxic insult, and then you have that watershed region where you start forming scar. You would like to repopulate those cardiocytes into that area of injury so that you would have improved remodeling. And they've done that. They've done ligations of cardiac tissue on murine models. And after they take the 7-0 suture out, I don't know how you get a 7-0 suture around the coronary artery of a mouse, but some guy with glasses can suture that. Not this guy. So anyway, they've done that. So after they ligate it, they've put exosomes in, and they've decreased the cardiomyopathy that results, and they've also decreased the remodeling, and they've increased the ejection fraction in the mice that were treated with exosomes just through the tail vein compared to ones that weren't. In the perfect world, if you come into the ER and I'm sitting in there, which I probably wouldn't be sitting in an ER unless bad things happen to me, but I would give you IV exosomes right after a stroke, right after a heart attack. And for some of these people who have horrible concussions, I could probably make a case for you to have intranasal. So I do intranasal now as well. I like to tell the doctors that the level of invasiveness should match the severity of disease. So when I'm doing intrathecal therapies, I'm doing these for pretty severe illnesses, lower in the lumbar spine, arachnoiditis, thoracic cord injuries, cervical cord injuries, spinal strokes, brain strokes, both hemorrhagic and non-hemorrhagic, Parkinson's, MS, Alzheimer's. These are really severe illnesses. Some of the other patients come in maybe with a concussion or autism. You're going to have a hard time justifying injecting the cervical spine of a 6-year-old autism patient. I don't recommend you do that. I've injected one autism patient in his 20s intrathecally, and he showed improvements as early as a week out with decreased echolalia, utilizing words instead of just pointing, and more focus, less tantrums, all beneficial things that the parents noted early on, and I believe is due to decreased inflammation. For many of these other treatments like concussion, I use a 1 cc tuberculin syringe with a 24 gauge angiocath with a couple of injections to the cribriform plate. So you can get these exosomes through the cribriform plate, for sure. Not bad. You're not puncturing. You're shooting it like a mist. So that's the way that we can rig it as physicians in our offices right now. And there's other ways to play. I don't do a lot of aesthetics. I do some hair and I do ED. And there's a myriad of applications between those two things with autoimmune disease and the like. We're hoping to engender more physicians to jump into the ring and start treating. Right now, it's important to realize that we're unregulated. So we are a cell secretion. You're not breaking any laws. We have our own FDA attorneys that we're deciding how to go about getting a final IND or an NDA, or whether we even need it. If it's going to be a 361 cell secretion product, we may just continue as we are now. We may file for an RMAT for some specific indications. which might be a fast track, and he can speak a little bit about that.
We were actually inspected by the FDA on October 24th, 2017. 2 weeks later, the November guidance came out from the FDA on cell therapies. And it specifically states, and I have this in my talk, that cell therapies are not regulated as an HCTP. And going forward, no one is going to be allowed to have cells in their product. And I didn't know it at the time, but when I was being interviewed by the FDA, they were specifically asking me questions about cells. And I was able to say, well, my whole company is based on not needing cells and has been for years. So I have protocols, I have material to support that. And I never heard from the FDA again. So that's not saying that might not change, but in one of the things it says in the guidance is the fluid in amniotic fluid is not an HCTP, but the cells in amniotic fluid are allogeneic cells and are therefore a 351 product, and you therefore need a BLA in order to be able to use them. But again, our amniotic fluid, and we have two. You said, where do they come from? We actually sell amniotic fluid, and amniotic fluid has exosomes in it, but I have removed the cells from it. So that came as collected straight from the mother. It saw the mother 6 hours ago. The exosomes that we make, the ExoGlow product, hasn't seen a human for 2 months because I grew the cells in the laboratory and I collect the exosomes from them as they grow. But anything that was related with the mother would have been diluted out a long time ago. And as I said before, I've used the same donor since the beginning, so I know there are no viruses or any kind of pathogenic items in it. So how do we know what these are going to do? I originally thought that the proteins in amniotic fluid would be the same as my exosomes. I make them from cells that are present in the placenta. Maybe they secrete. When I ran this panel of about 60 different inflammatory and growth factors, I found two entirely different products. And if you want to take the time to look up every one of these proteins, it'll tell you exactly what you want to do. It's a roadmap. There are proteins in here that will grow bone. There are proteins that can grow collagen. There are the most important anti-inflammatory proteins known, which is TGF-beta 3. TGF-beta 3 can convert an inflammatory T cell to an anti-inflammatory T cell. Therefore, if you have, for instance, Lyme disease, chronic Lyme disease, and you have arthritis from it, that T cell is seeing an antigen that was present in the pathogen, but the pathogen hasn't been there for quite a long time. But it's also recognizing proteins in the knee that's causing that arthritis. By adding TGF-beta 3 to the environment, it turns that cell off permanently. So amniotic fluid, we know it works. It works because it's temporarily anti-inflammatory. It has TNF receptor and IL-1 receptor, so it binds up those proteins in the milieu and stops the inflammation. Exosomes, the way that we make the placental-mesenchymal stem cell exosomes, are permanently anti-inflammatory. And there are other proteins in there that are important as well.
So when we worked on this chapter together, we actually went through many of the more important proteins as well as the messenger RNA that code for those. And if you look on pages 14 and 15, that'll be included for you. So those are some of the high points of some of the more interesting ones that you can discuss with your patients. We want you to have the information to discuss the science so that they understand why this treatment is different than everything else that's been offered. This is a useful treatment. It has a myriad of appropriate options. And realize this, there are a number of companies currently pursuing exosomal products. Hundreds of millions of dollars are being spent in the space right now because right now you have a generic pro-growth anti-inflammatory product. Consider this the first floor. The second floor will be specific exosomes from specific cells. We go up to the third floor, we're going to upregulate certain messenger RNA for certain proteins and maybe culture them in acidic environments or hypoxic environments to get a different output. We can then change the protein ligands, which are the cellular receptor molecules on the walls of these tiny vesicles so that they attract to different tissues. And finally, we can use the Trojan horse. We can take one of these vesicles with a very specific protein ligand that may go to a cancer and load this little nanocarrier with very tiny chemo agents to deliver directly to the cells in question. So you're on the first floor right now, and you're part of the generation on the very, very beginning of this upward curve. Through you and your patients, this will change the field of medicine, much as penicillin did around World War II.
And it's really our ability to provide a repeatable product. I know the concentration, we know the proteins. I further know the messenger RNA that are creating those proteins. We've identified an important protein for the anti-aging market, which is called GDF11. In that parabiosis experiment that he was talking about, the one protein that was found to repeat from experiment to experiment was GDF11, and that's why people were interested in it. But there are other proteins that are responsible for these outcomes as well.
So if we have a few minutes, maybe we'll field some questions now, because that's kind of a brief overview. You can read more about the science in the article. Yes?
How do you get to a exosome product? How do you, if I want to go,
Oh, how do we make the secret sauce?
how do I, if I want to get some patient, how do I order?
Oh. So we have a number of distributors. We have some here, and we can talk to you outside of this here.
You don't know directly from you?
So the question is, have we used it in chronic kidney failure? There's an article for a group that is used specifically umbilical cord blood for chronic kidney failure. I have one of my doctors out on the West Coast had her husband who is anuric and delivered exosomes intravenously. Within 3 to 5 days, he started peeing. So that was a real bad chronic kidney failure. The other report in here is patients that were treated with grade 3 and grade stage 4 chronic kidney disease, and all of their GFRs improved and their BUNs and creatinines all decreased. You don't need regulations. No, these are currently unregulated treatments. You want to use. Yeah, I do pre-testing. So I test. So if you're a young lady and you're above 40, I'll ask if you had a mammo. If you're a man or a woman above 45 or 50, I'll ask about colonoscopy, prior cancers, other things that I may not want to increase your pro-growth milieu, if you will. But I do that testing, and that's included in here. I do certainly MRIs and CAT scans and CT angiograms and MR angiograms if I'm putting a needle in a very difficult place and I want to be sure that there's ample space.
For the kidney disease, you
Intravenously.
So what type of the test do you use?
So a 35-year-old patient with chronic kidney disease, certainly I would look at certain tumor markers. I'd probably look at CEAs, woman CA125, a man PSA. I'd get some basic bloods like CMP, CBC. Maybe if I want to look at the coagulation cascade, PTINR, I'd probably get a UA. And then if they had basically a good history with no cancers or anything else that I thought were relative contraindications, I'd invite them in. I usually give a little Benadryl prior to injection, and I infuse them over about 30 minutes.
How much it costs?
We can talk about that outside the room.
How about liver cirrhosis or
Right, so we know that in biodistribution tests, the exosomes will be preferentially picked up by Kupffer cells of the liver. So we believe this will be a significant boost towards regeneration of liver disease. So a good question. For neurodegenerative diseases, I generally utilize both intravenous and intrathecal.
Can you combine that with your stem cell too?
You certainly can, and I spent a year as a blender with stem cells and exosomes before I switched over. There's absolutely no risk in doing that. But remember, the side effects will come from your stem cells, not from my exosomes.
We talked about earlier, joint disease, where you put exosome and stem cells together in the knee.
No, I don't use stem cells anymore.
No.
I use PRP or PRFM as a scaffold,
And then
and I use them together in the knee utilizing a 22 gauge needle.
they will stay localized. They won't move.
Well, the idea with the scaffold is that you kind of hold them there for a while. Remember, they'll traffic pretty quick in an open space otherwise.
So it will have unintended positive side effects of some other organ that you don't know there is something.
Yes,
you
yes.
fix it.
So there's a portion of the chapter where we talk about diabetes. So there are some interesting ways that this helps type 2 diabetics. Right, by the time we're 65, roughly 50% or more of us will either be type 2 diabetics or insulin resistant. And that's a huge risk factor because those are also the comorbidities that lead to heart disease and stroke and many of the other afflictions of later life. Well, the exosomes do some rather interesting things. They decrease apoptosis of beta cells in the pancreas. They increase the insulin binding to insulin receptors in your body. And on a multi-phase level, they increase a number of things. As we get older, we demonstrate sarcopenia, so we lose muscles. One of the main reasons we lose muscles is something known as capillary rarefaction. We stop having enough capillaries in our muscles. With capillary rarefaction, there's less nutrients and less ability of nutrients and glucose and insulin to get to these muscles. There's also less muscle tissue, which is hypermetabolic tissue to begin with. And as that happens, you're going to lower your metabolic rate. When you add exosomes, you're adding VEGF as well as the mRNA that codes for VEGF. You're going to have capillary growth. That capillary will then bring secretomes and exosomes to the muscles. You'll wake up your satellite cells of your muscles, which are your predecessor stem cells of muscles. They'll turn into muscle tissue. Your muscle burden will go up so that your metabolic rate increases. And now as you have more muscle tissue and more capillaries, you have easier transit for both insulin and glucose into the cells, so you'll have more effective transportation of both of those things. All three things together, you should dampen your hemoglobin A1Cs as well as your postprandial glucoses.
Have you tried just IV infusion in generally healthy aging adults and see what it does for them?
I kind of feel like he fed me that question. So I'm part of a 3-physician panel for Larry King later this week. And in the panel, we're talking about longevity. So the real question is, can we change the thermostat and turn back the aging? I think there's 2 parts to that question. Number one, are we seeing aging as a disease yet? Which you should be, because by the time we're in our 3rd decade, catabolism starts outdistancing anabolism. As that happens, 2 real bad things happen in our bodies. One, we run out of energy. So we have mitochondrial dysfunction, right? That's the powerhouse of all of our cells. So you have poor mitophagy, which is getting rid of mitochondria that aren't yet dead. We have abnormal morphology of the mitochondria, and we can't make as much ATP as we should. So the cells become sluggish and senescent, and they secrete bad inflammatory markers. If you can decrease the amount of inflammation, which we know we can with these, and increase the health of the mitochondria, which we can by improved mitophagy. By the way, we're increasing the delivery of the five key enzymes to the ATP glycolytic pathway. Those are within our exosomes. So if you can increase the energy and decrease the inflammation and make your cells act like they did when you were younger, I would argue that we can live longer and we can live better. So while we're not currently gathering data for this, my best guess for right now, there is a predicate study that evaluates renal function using umbilical cord MSCs in stage 3 and 4 chronic kidney disease. They use 100 micrograms per kilo of 2 separate injections. One is intrarenal and the other is intravenous. So in a 70 kilogram patient, that's 14 or 15 milligrams. My general IV dose is 3 times that, 45 milligrams. I see some significant changes. In their study, their anti-inflammatory milieu peaked at 12 weeks, but persisted for better than a year. I think you could make a case for giving 45 milligrams 2, 3, or 4 times a year, and I think you could all live longer and better.
Is the IV dose taken up by all tissues, or is there any preferential?
So there is preferential uptake through rodent and murine models. We know that the preferential biodistribution early on is liver, spleen, and lungs. And then there's a quick, within 360 minutes, where it's metabolized and basically untraceable in about 6 hours.
You noticed any change with high blood pressure?
So I haven't been tracking that in my patients. Good question.
What would be the age you think will be too late for that?
When you're dead.
What would be the earliest time you think you could consider doing that?
Well, if anyone wants to appoint me the Minister of Health, I would make a case that in your 30s you start treating, and it, you know, in our lifetimes, what makes everything balance is the almighty buck, right? So the insurance companies want to pay for things that make sense to them, business sense. They want to cover certain procedures that have evidence-based medicine therapeutic benefit. So for patients who have these things, they're willing to treat you after you get the affliction. If you could show the insurance company that you're going to have less severe years in your 50s, 60s, and 70s, that you're going to have cost containment in those decades, they will likely in that future life, maybe while we're still here, pay for us to have regenerative therapies before we get those secondary diseases, at which point we're treating aging as the disease, not the secondary diabetes, cardiovascular disease, stroke, atherosclerosis, and cancer.
Yeah, I'm not like for me, I don't have any disease. I don't give any medication. Let's say I'm 50 years old, and should I start this without considering about money?
In the perfect world, I would say yes.
So you take 2 to 4 times a year.
That's my best guess, given the literature that I've read. That would be the high end of treatment as per my best guess.
For how long? 2 to 4 times a year. How long?
Till you're still with us.
So where do you practice?
I practice in New Jersey, yeah, so I can give you cards after.
Talk about the machine a little bit because they
Sure.
want to know that too.
Sure, I got to give you, if you give me
Kidney disease also we have to repeat?
I would tell you to track the numbers.
About COPD.
COPD, there's a protocol in there for that as well.
You have that now?
I do.
Now healthy, it doesn't hurt to do it, right? So
I would say it's a very good idea to restore the milieu of a neonate now rather than later. All right, so let's talk a little bit about shockwave therapy while we have a few minutes. I consider shockwave therapy really the first stage in regenerative medicine. So for many of you who are doing regenerative therapies, this is a nice non-invasive way to start. And if you're billing for injection procedures, this is a nice way to encourage the patients to get the injection, and you throw a few of these treatments in with it. So what you do here is with these heads, these can be used for erectile dysfunction. Excuse me a second. So these can be used for erectile dysfunction. They can be used for most of the muscles, tendons, and ligaments of your body. There are different heads to be used. And what they do is they cause microcavitation. So this is a medium intensity wave when you're dealing with musculoskeletal. It's a low intensity wave when you're dealing with ED. And if we were using lithotripsy, that's considered a high intensity wave. So all of this is based on the lithotripsy data of years ago. And they found with microcavitation, you were basically causing localized inflammation that begets stem cells to come into the area, activates them, and then they go on to retreat and rejuvenate or repair or regenerate the area. How do we know that? I think the best way that we know that is some of the secondary studies that came out. So they've looked at patients who've been non-responders to Viagra, Levitra, Cialis, and similar phosphodiesterase 5 inhibitors. In order to be a responder, you have to produce some level of nitric oxide. No nitric oxide, no erection with those things. You'll still get an erection with Trimix. So what they did is they took these really sad sacks, these poor guys that weren't getting any action, even with fistfuls of Viagra, and they treated them. And they treated them for 6 treatments twice a week, 5 to 7 minutes each. They did 1,000 pulses on the base of the penis on either side, 500 every tip stamp along the dorsum, and they tracked those patients. 70% of those non-responders became responders with or without Viagra, Levitra, or Cialis. So clearly they introduced nitric oxide, which is a very short-lived substance to the tissues. What produces nitric oxide? Veins and nerves. So theoretically, this is secondary evidence that this stuff is angiogenic and neurogenic. Now, if you want to look at stem cell studies, they've taken SVF bags and they've treated it with shockwave. And when they look at the exosomal broth and the secretions, there's higher secretions than the ones treated with shockwave without rupturing all the cells. And there are other things that upregulate stem cells, some laser light, hyperbaric oxygen, but this definitely works in that respect. If you're dealing with a plantar fasciitis or Achilles tendonitis or a turf toe, or you're dealing with patellar tendonitis, and you get 3 of these maybe once a week for 3 weeks or maybe 3 to 6 times, and it goes away, you can stop your treatment there. There's a gentleman at special surgery, I kid you not, 6 or 7 machines, $450 per treatment. People are walking in every day with their black card. I went and met the guy. He's a podiatrist. Very interesting guy. What does he do? He does this. This is his business. Does it work? Yeah, it works. Does it work for everybody? No, it doesn't. It's the first stage, right? PRP doesn't work for everybody. The exosomes work for virtually everybody. But this is an excellent way of treating people. And if you're billing for injections, it's perfectly ethical for you to throw this in with it. If you want to charge them a few shekels above, it's fine. You're not spending a lot of disposable money on this. So once you buy the unit, I have 3 units. I actually have the older, and I've got one just like this. But it takes one of your office staff. It's a type 1 medical device. So anyone in your office can do it for you. Your medical tech can do it. You can do it if you have time. Even on ED, the disposable is basically a rubber condom and some gel in the 7 minutes that it takes them to treat your patient.
It only helps erection, not help ejaculation.
You need a partner for that. Peyronie's, there's slightly higher settings for that. Yeah, no, if you have retrograde ejaculation, I don't know if this is going to help that system. And there are, yeah. All right, I think we're going to break here, and we'll call it a day. Okay?